was excellent. Have a seat. I'd like to invite all the other panelists to come up, and we have time for some questions. I do two comments. One is I got some statistics. So when the portal for this meeting crashed, at the time that occurred, there were 170 hits per second, which I think, except for people Googling Miley Cyrus's latest adventures, that's probably a record. So, we have anything from the audience? I can start things. And Fran, you hit a home run, because that's exactly what we wanted to talk about. But what I was struck by was your overlap between some of your thoughts and those of Chris Attinger. And Chris actually quoted some work that Spence Taylor's group has done in Greenville. And if you think about it, of course the outcomes should be patient-centered. But something you didn't quite get at, which Spence Taylor's work has touched on, is also you have to look at the patient's functional status when they show up, when you see them. So that's something that we haven't really talked a lot about. In his work, it's one center, but it's a big experience. And I think it's probably true, is that the functional status of the patient when you see them has a huge effect on what your outcome is going to be. Because if they're minimally ambulatory because of their overall decreased stamina, overall health, then your goals in that patient are going to be different, right? So you want to address that a little bit?
Hello. Yeah, so for us, interestingly enough, the younger and the more athletic you are, the more likely we are to go to a BKA if the leg doesn't work perfectly. The older you are and the less your activity, the more likely we are even to save a peg leg, because we realize donning a prosthesis at 70 with failing eyesight and rheumatoid arthritis is a tough go. So counter to what you would think, we try harder in older patients to save the leg than we would in a younger one when we realize that if we saved it, it wouldn't be as good a leg as if it were with a prosthesis.
Yeah, we actually agree totally. I don't know if Joe Fiorito is here. I saw him earlier. He was our SALSA fellow a couple years ago. And we had two patients that if you looked at their wounds and their classifications, however you wanted, they looked identical. One was younger and wanted to get back with the life and had already been held up a long time by various efforts at wound healing. And that patient got a BK and was walking pretty quickly. The other patient was a little older and wanted to keep his limb and didn't. His functional level was much like, I think one of you showed a patient where the guy goes to the TV and sits back down, goes to the bathroom, doesn't have to put anything on. He's not an athlete. He's happy with that. So that gets back to what we were talking about. I'll get to you in a sec, George. Spence Taylor gave you the analogy. So when vascular surgeons and different vascular specialists treat arteriovenous malformations, we can't cure most of them, right? So one of the ideas is that you look at the patient and say, well, what do you want us to do for you that will help your quality of life? Or what kind of outcome are you looking at? And maybe we need to be doing that a little bit more with our patients rather than trying to look at some, like limb salvage. Okay, you can have your limb at a year and you still have a non-healing wound. That's still limb salvage, but is that the real outcome that helps the patient? Dr. Andros.
Thank you. I'd also like to congratulate all the speakers. I thought those were 4 wonderful talks, and it gives me hope for the future that I've been listening to this now for 15 years, and we keep getting fresh insights into this problem that seems not to want to submit to our administrations. I rise more to make a comment than to ask a question, but I'd like to hear what the other people have to say. We all talk about the team approach, and we babble on about it, think we're doing a good job. Quite by accident in our own unit, we have a large unit with a lot of beds, and we have a floor of our hospital. And just by chance, around the corner is the rehab unit. And we found that we had patients that we were fixing their ulcers. They'd come in on a gurney, and they'd go home on a gurney. And I said to myself, that's not a success, that's a kind of a success. It's the more patting yourself on the back than helping the patient. So we instituted a policy that went something like this. Even if you didn't walk in, you're going to walk out. And we sent the patients to the rehab unit. And we wouldn't discharge them from the rehab unit until certain endpoints were reached. The worst one was, of course, that Medicare would throw them out. But setting that aside, we would often keep them for 4 to 6 weeks in the rehab unit, and by which time all the patients were able to walk out. So I think in considering our teams for the future, we should not be thinking about the GP and the community nurse and the podiatrist and the vascular surgeon and not remember the rehab unit so that the patients can walk out. Just a comment.
Dr. Uccioli?
Hi, Chris. You did show some attractive pictures of amputee patients. But I think that we have to discuss a little bit more on this topic because you know that several data show that amputee patients have less lifespan than the non-amputee patients. So I think this is a very central point to discuss because, you know, probably the choice is correct for young people, as you have shown, but this is not the rule in our patients. So I think that all the force to save the leg is important in those patients.
So I would that my data may be somewhat skewed because it's patient-centric. And so the older you are, I'm going to do everything to try to save the leg. The younger you are, they're all diabetics, but the younger you are, more athletic you are, and if I can't give you a good leg, I'll do it below knee. So that population, that low mortality rate at 18 months was in large part due to the fact that we had a younger population of BKAs than the group that we treated whose legs we saved.
At least in our experience, in our patients, when we have young patients, they are type 1 patients, type 1 diabetes patients with a very long disease duration and a lot of other long-term complications. So those are the worst patients. In fact, those patients die within 50-55 years. Mm-hmm. So I think we have discussed a lot about the choice of amputation because probably this approach is true for patients with traumatic amputation, for lower PAD amputation, but without diabetes. Because our patients with diabetes have the worst outcomes, mainly when they are amputated.
I absolutely agree with you, Luigi. And I think part of the problem is that if we continue the cancer analogy that we've used several times today, is that when a patient is assessed for treatment for a cancer, for chemotherapy, they look at their age, their functionality, their comorbidities, and they assess what the outcome will be with that patient with and without chemotherapy. Are they fit enough for this treatment? And that's something that we don't do with our patients. We don't sit down with them and say, you're this age, you've got this degree of renal impairment, your vascular disease, this is your predicted survival, and if we do an amputation, this is likely to be the outcome. We don't do that. We're not as good as the cancer specialists. Maybe that's because we're actually not as good as the cancer specialists about talking about mortality with our patients, even though we know the mortality is as high.
You know, I think one problem is we don't have as good data, I think, for some of it, so that makes it harder. And I think the general message is still there's far too many limbs taken off that could be saved with adherence to basic principles. But I think what all of us see is when you get in a center where you're trying to save limbs, we all get patients where at the end of a long ordeal, we may have actually hurt the patient. And what actually Spence Taylor's group showed that too. If you take the really high-risk group patients, they actually have a higher mortality at a year when you do really aggressive attempts at limb salvage. That's a subset. We're not talking about every single patient. Over here, sure.
Yes. This is directed somewhat at Dr. Attinger, but I appreciate your comments too because that partially answered what I was talking about. I have a dilemma. We all see a lot of diabetic patients. Often they have vascular compromise, critical limb ischemia, they have an ulcer, they have infection, and they have renal disease. They may or may not be on dialysis, but they have renal insufficiency. One particular individual's on hospice, has severe pain, and is this a person with gangrene in his toes? How much do I do? I mean, I do want to give him comfort care. And some of these people, is it just comfort care? Is that really what we're rendering for these people who really, for example, on dialysis, really don't have a long lifespan ahead of them anyway? What are your views on that?
Well, I think there's a real role for hospice care for those patients. I think we if we have to do anything significant, we have them cleared by cardiology. Many of these patients, it's just like doing vascular surgery, where you need a cardiology clearance. We see what we may have to do to save his leg, and we have them seen by cardiology, and then we evaluate the risk, and we tell them there's nothing wrong with wound care. If we think that the risk of saving the leg is too much and taking the leg off is too much. So we have a lot of palliative care.
And the palliation, I guess one of the dilemmas that it was presented to me is the presence of pain. If it's a neuropathic patient, the palliation is not too much of an issue. But in the presence of pain, I mean, I sent him to the vascular surgeon, and you kind of expressed a dislike of endoscopic procedures, but on the other hand, open procedures are not, even amputation may not be indicated. So I just was confused a little bit.
Well, we have a concept, we actually call it wound hospice. When there's a subset of patients that are very frail and elderly, and if you measure their frailty by any standard scale, it's really, really low. And they have a smallish wound, maybe they don't have any pain, it's not infected. If we can keep that patient in whatever setting they're in when we see them, and keep the wound clean, and not make them have to come to the doctor too much until they die of their disease process, I think that's humane, and I think that's better. The temptation is, well, I'll try something endo because it's less invasive. But if you actually look at the mortality in that subset of patients that are high risk, if they're high risk for open and they're high risk for amputation, they're high risk for endo too, because it's the same patient. So we do have, I can't give you a percentage, but we frequently do that. We get very frail patients who look like a haircut would be a large endeavor for them. And the key,
With that in mind, excuse me, my question was, would you consider it comfort care to amputate a limb rather than try to restore it? In a person who's having severe pain and ischemia, would you just consider comfort care amputation?
In those cases, I would wait till they ask for the amputation. I would want their pain to be such that they say, I can't live with this.
Okay, thank you.
I think we do that less frequently. Usually there's ways to control pain, and it's a subset of patients also, but pure ischemia is something we see less. We get more of these mixed pictures of wounds, and what kills those patients is when the wound gets infected, right? So that's what's left out of a lot of the, Fran went through that a little bit, but a lot of classification systems, especially all the vascular ones, act like infection doesn't exist. In the real world, infection actually is what drives amputation, even in those patients that are ischemic. So, Stephanie, how far are we away? I love your talks, and I get inspired every time I see them, and they make sense to me, but how far are we from having something that we can use in the clinic that's effective and relatively easy to use and at least gets covered by somebody so we don't lose money on it?
That's a great question. It really depends on your definition of effective, because a lot of the advanced modalities that we have currently on the market are effective. However, it's really the impedances, all the inflammatory cytokines that's in the wound that's impeding them from healing. So if you take that away, because you were able to show that yes, they can push them to healing. So the depression of these growth factors, they're all there. However, if we're able to really convert these those inflammatory wounds so that they're less inflammatory, that would actually be the time where we see greater than 90% success rates.
My question goes to Dr. Attinger. As you mentioned about the TMA transmit amputation, you mentioned about the Achilles tendon lengthening. How about, instead of Achilles tendon lengthening, how about gastrocnemic recession, which is more proximal and give more better wound healing after the post-op surgical incision? So how about that?
So, excellent point. We will do a gastroc recession preferentially to a percutaneous release if the gastroc is a tight portion, because there you avoid the possibility of calcaneal gate. So I would say our ratio of percutaneous to gastroc is probably gastroc 60%, 40% percutaneous.
Dr. Romanelli, you talked about dressing some. How frequently in your unit do you use some sort of vacuum-assisted closure? Is that something you use commonly now, or not so much?
Say it again.
Vacuum-assisted closure. You went through, so we try to keep dressings as simple as possible, And sometimes that makes things simpler because the dressing doesn't need to be changed as frequently, so there's less chance of the dressing being done incorrectly.
We've been practicing negative pressure with the so-called ultra-portable devices more and more, because on the foot particularly. The exudate amount is not the one like we have in venous leg ulcer, for instance. So might be a chance not to go to complete healing, but at least to do kind of wound bed preparation, like skin grafting after.
Right, well, the VAC gets you to a point where you can do something else. This doesn't usually get you to the end point.